My name's Kylynn and this is Nyree, and we're here from the Spark team. We will be talking about the work that we've been doing looking at functional status models. So before we start, I was going to say not much about Spark, as Richard said. Kate, and actually I think it'll be Kate, will be talking about Spark a little bit later in the session after morning tea. But essentially Spark is a national fire accelerator really looking to improve the develop and improve the use of data standards for healthcare exchange. But one of the products that we are working on within the Spark program is the Australian Clinical Data for Interoperability. And that's really just the collection of data groups and data elements representing the clinical or patient care requirements for data entry, data use and sharing of health information to help support care. So we've been developing this in an agile sort of iterative manner, and we are developing it to evolve to include healthcare that will support care across a person's life, across the health continuum, so preventative, acute and chronic care, as well as across the health ecosystem, so all domains, private, public, from primary to population health. So it was really important for us as we develop AECDI to think about how data needs to follow the person. We know that people are not one thing. As we progress along our health journey, we use many services. We don't just use one thing. We don't just fit into one place. So, a person may be using aged care services and primary care, allied health services, other medical specialists, private and public pathology and diagnostic services, hospital services, and many other things as well. So as we started to develop our models to support healthcare, we need to think about how can we support models that cross across all of these. And so one of the items that we have been looking at is functional status. What does it mean, not just in one care setting like allied health, but also in disability and aged care and general practice as well.
Okay, so we're going to do a deep dive into functional status, and this is a really complex space. And we've heard a couple of the presentations this morning that have talked about the complexities involved in trying to understand how a person functions. So functional status is typically characterised by what the thing is that we're measuring, whether that's mobility or independence in attending to ADLs like walking or dressing or bathing or toileting, but also it's quite complex because it's contained within how we actually measure them. So there's lots of functioning tools that we're going to go through a little bit later, but you'll see there's a breadth and depth of these screening tools that try to understand and categorise this information. So the functional problem space, it's really, really complex, as we mentioned before. And as on this slide, I like to sort of frame it as a patchwork quilt. What we're trying to do is understand function within the scope of development of that person. So on the screen, you can see we've got a number of data groups that we've already previously published in AECDI. So health issue and care plan and problem diagnosis and procedure. But there's a couple of others that are there that we don't really have data groups yet for. So Braden scale is one of them, but we're trying to understand how do we actually record that in an electronic health system or an EMR. So when we assess function, what are we trying to put together? We might be looking at how they shop or the ADLs or their foot care, or we might be looking at dimensions like the physical aspects of their way that they function or the person functions. We might be looking at communication mechanisms. We might be looking at sensory aspects of the person. We might be looking at how they are getting their nutrition. So what sort of things they need assistance with in terms of meal preparation. Do they have a peg tube? And we also might be looking at things like their self-management, following a care plan, understanding how to take their medications. There also might be some social context to the functioning aspects, so how they operate within the context of a group, or are they able to go outside and go to the bank and go to the shops and be able to get their groceries. And then, as I mentioned before, there's numerous ways of us trying to understand how we measure functioning status. We have all of these different tools that exist across the world, basically, and trying to bring them together to try and understand, are they actually measuring independence? Are they measuring how well the person performs the activity or participates in the activity? Or are they measuring something to do with their impairment? There's lots of different scopes. There's lots of different indicators and metrics that are used within these tools that don't make them like for like, basically. Okay, so how do we measure it? I've mentioned before that it's actually very complex, but when we deconstruct it, I'm going to take you through now the journey that we go on when we're doing the clinical information modelling. And that is that we try and understand what is it that we need when we're operationalising it, in clinical practice. What does the research say? And then how do we then try and model it for a system? So when we deconstruct functional status, we understand that it's actually the person's ability to participate in an activity, the level of independence in that person being able to perform that activity. So we use that sort of scope or that frame of lens when we're sharing continuity of care between shifts or between service provision. And we need to understand their capacity, the difficulty of them being able to perform the task, and what assistive technologies or human assistance that individual might need to perform and participate in that activity, and also the degree of the impairment, how much that impairment affects that person being able to perform the activity. There's a lot of research that we go through to try and help inform the clinical design and clinical information models. So for this area, we looked at the International Classification of Functioning and Disability and Health, and they classify functioning into two main areas, so body function and then how well the person can participate in the activity. And then the functional independence measure is a common independence measure, that metrics that's used across the world, which is actually looking at the level of independence, how much modified dependence they need, so whether they need supervision or they need some assistance, and whether they are completely dependent. So it's not black and white. And then when we looked at the literature and did a little bit more of a deep dive, we kind of understand that the clinicians think of a functioning status very differently to the way patients do. And it's often dichotomised. So either they're independent and able to perform that activity, or they're fully dependent and unable to perform that activity. And that's kind of really black and white and way of looking at the way functional is documented in the research papers. But patients have a very much broader, more encompassing understanding of the way they operate or way they want to function. So they take into that grey space, which is more about the way that, they might be participating in activities such as writing, playing, socialising, reading, or listening to music. So if we take a look at the Braden scale, and this is probably quite common to a lot of the clinicians in the room, we can see that the two yellow arrows on the slide at the moment are looking at the way that an individual might perform an activity. So at the top, we've got feeding, bathing and grooming, and at the bottom, we've got transferring bed to chair, and we've got the level of mobility. But in the middle, we've got assessing body function. And this is a standardised tool. The Braden scale is very well known, used in a lot of nursing services across the healthcare service. And we can see that we're measuring very different things. So when we're looking at the data, we really want to understand the discrete data groups around what it is that we're trying to measure. And we need that because we need to use that data for things like clinical decision support, or we might use it as an underpinning for AI agents, or we might be using it in population health instances. So these three components often are really quite independent. So where we got to was that we needed to look at ability first, and the hexagon on the left, the functional ability one, is what is more about what the individual can actually do. And this data group has gone as part of AEHRC R3 and has just been released for community comment. So if those of you who are interested in the functioning suite, I'd encourage you to go and download AEHRC R3 and provide your feedback. And the other two on the right are around the complementary space of functional status. So we typically will need to know as clinicians, what can the individual actually do, which is the functional ability, but we also then, for continuity of care, we want to be able to tell another clinician what that individual might need. So functional independence and functional impairment summary will complement those. I'm going to quickly race through because I've just heard the alarm. But these form a suite of other complementary data groups. So you can see on the left, developmental milestone is also been part of our latest release for AEHRC R3. And the problem diagnosis summary, which is in the orange, is part of the AEHRC R2, which was released last June. This is a table. I'm not going to go through this, but if you'd like to come and talk to us afterwards, we've got a stand and we can go through. It's just the breakdown of the data groups and what data we might be capturing in each of those different models. And this is the functional ability data group. I'll just quickly whiz through. I've got some descriptions and things there. And just to complete the story, this starts helping us to form as clinicians the patchwork quilt about that person. So we're trying to bring all of the data together, that we need to be able to understand what it is and how we can better improve outcomes for our patients and improve our practice. So we can see that there's lots of different data groups there on that slide and we're getting different information. So if you'd like to be, or you're interested in around the clinical design group and providing feedback for the information models, I'd encourage you to scan the QR code. There's the AEHRC design principles and the AEHRC R3 draft for community comment, the QRs, they're both there. And I'd like to extend this invitation now for you to become part of Sparked. There's a podcast and then there's a LinkedIn post. And I'd like to also acknowledge that none of this work would have been possible without the broader community input. And that's been happening for just 2.5 years, almost 3 years now. So all of the Sparked community would just like to show our appreciation.